So welcome, everyone who's in attendance. Thanks for joining us. We're honored to have Dr. Esther here tonight to speak to us about the recent conference. I'm going to introduce Dr. Esther and then turn it over to him, and then I'll turn off my video for a little while, but I'll turn it back on once I get to my destination. But Dr. Esther obtained his MD and PhD degrees from Emory University in 1998 and then completed pediatric residency and pediatric pulmonology fellowship at the University of North Carolina, Chapel Hill. He has been on faculty at UNC since completing fellowship in 2004, providing clinical care to children with CF and other respiratory diseases while maintaining an active research laboratory. He serves in multiple leadership roles at UNC, including Director of Clinical Operations for Pediatric Pulmonology, Director of the Pediatric Pulmonology Fellowship Training Program, and co-director of the UNC CF Foundation Research Development Program. He also recently became director of the Pediatric CF Care Program at UNC. Dr. Esther's passion for CF began early in his training as he formed close relationships with several CF families during residency. This passion extends to his research, where his laboratory focuses on using mass spectrometric methods to assess disease-related biomarkers and drugs in respiratory samples such as I'm sorry, I can't, my glasses on. Anyway, lavage fluid, sputum collection, and exhaled breath condensate. He's used these studies to better understand the pathophysiology of early CF lung disease, as well as other diseases. I'm going to turn it over without further ado and go flubbing over any other scientific terminology and turn it over to Dr. Esther. But thank you so much for speaking tonight.
Oh, well, thank you for having me. So very happy to be here, talk a little bit about NACFC 2023. Apologize, I don't have any slides. Most of the sessions from NACFC that I think were the most critical were available on video. You can actually watch them on YouTube if you want, but that does make it a little hard to pull things out for a slide presentation. So I have my own notes, but I won't be sharing anything via Zoom. So, and before I get started, first, just want to say I'm happy for this to be very interactive. So if people have questions or particular items that they wanted to know about that were happened at conference, feel free to interrupt and ask questions. That's not going to bother me at all. Then the other thing I want to do before we get started is brag a little bit about our program. We always have a good representation in the scientific sessions between the MD and PhD faculty. And again, we had about a dozen people who were speakers at NACFC in various contexts. But what was really fun for me to see was how many of our non-physician providers actually had speaking roles at NACFC. So our pharmacists, Cameron McKenzie and Carissa Camp, both were speakers in multiple sessions, actually, on effects of Trikafta on drug levels and on insurance coverage and things like that. And even our pharmacy technician, Billy Sutton, who many of you may know if you're part of our center, actually was part of a speaking role talking about the pharmacy team. Then our nutritionist, Kelly Baumberger and Kimberly Stevenson, both had presentations. And Mary Beth Pryor, who many of you know, one of our psychologists who works with a lot of our folks with CF, had several roles on mental health. And then for those of you in the adult center, Courtney Busby actually also had a speaking role on nutrition and GI collaboration. So we were very pleased to see so many of our group have such a prominent role within the conference and help with the education. So one of the things that I brought back from NAC was some nasty respiratory virus that kind of kept me out for a week after the conference. I still have a little bit of post-viral cough every once in a while. So if that happens, just know, I mean, we're on Zoom, so I'm not going to get anybody sick, but I may have to take a sip of water or something during the talk. So, excuse me. Does anybody have any particular questions or things that they want before I get started? All right, so NACFC 2023 took place in Phoenix, Arizona. It was a very well-attended conference. I was actually very pleased to see how many people were there. Most of the sessions, actually, certainly early in the conference, were standing room only. There weren't enough seats to go around, even though they were, it wasn't like everyone was taking every other seat. People were kind of crammed in. So that was really good to see. We always worry that there's going to be this perception that with Trikafta that we're sort of moving on from CF as a scientific endeavor, but that we certainly don't think that's true, and that certainly wasn't present at the conference. So this was not a conference that had any huge breakthroughs to present, certainly not like 2019, where Trikafta was first introduced. I would say that there were, in my opinion, four kind of main topics that were covered at the conference. One was on the long-term and real-world impacts of Trikafta, or ETI as we call it when we're not using the trade name. Another was genetic therapies. So where we are, what progress are we making there? There was a good focus on CF microbiology. We certainly know that infections don't go away with Trikafta, and certainly people who aren't eligible for Trikafta are still struggling. And then sessions on CF and mental health. For those of you who like to see the real science part of it, I'm not sure how many people are aware that a lot of the videos for the plenary sessions, symposia, and even some of the workshops are available. If you Google NACFC, you can find it. I think it's nacfconference.org is the website. I may have that not quite right, but it's something like that. There's one symposia in particular, Symposia 2, which is a year in review, that covers a lot of really interesting topics. It's pretty in depth, and it's pretty sciencey. So it's definitely reviews of manuscripts and things like that. But if you like that kind of thing and want to get a really dense review of a lot of stuff that's happened over the past year, I would recommend looking at that symposia. They cover CFTR modulators in children, treatment of CF exacerbations, CF GI and liver disease, and CF related diabetes. So again, it's a really good, succinct but dense update on a lot of stuff that's happened over the past year. So in terms of real world impact of ETI, what I would say that there were a number of posters and other presentations that show that a lot of the clinical benefits that we saw from Trikafta early on appear to be persistent and maintained over time. So lung function stays high. There's not really clear evidence of ongoing decline, although we're still early, so it's hard to say exactly what's going to be going on with that. A lot of other features, so diabetes, liver disease, seem to be stable or even perhaps better. Fat-soluble vitamin levels tend to go up for patients that are on that therapy. So in general, we're seeing ongoing sustained clinical benefit. It is clear, though, that the benefit is related to taking the medication. If you stop it, a lot of the features of CF come back. We've seen that anecdotally with a number of people that either were not compliant with therapy or had to stop for medical reasons. And we've seen the airway inflammation and other things come back fairly quickly. So it is definitely something that you need to keep doing. We're not, the dosing is not really clear. I'll talk about that a little more when we talk about mental health. And it may be that lower doses will still be effective at providing the clinical benefit, but that's an area that hasn't really been studied that much to date. The flip side of this is that some things that those of us of my age have to start worrying about, like weight gain, heart disease, elevated lipids, also seem to be an issue for people on Trikafta. So cholesterol levels are going up. Some people are getting into the obese range, some, not all, but some. So it's the double-edged sword, right? The physiology is becoming sort of more quote unquote normal, but normal physiology also involves a lot of potential for developing heart disease and other things that may become more and more problematic as our population ages on ETI. So that is definitely something we're looking out for and trying to figure out. Does anybody have any? So I'll go over just so that you guys know. I'm going to review sort of each section in turn. So starting with the impact of ETI in general, then genetic therapies, microbiology, and mental health. But if anybody has any particular questions about the impact of ETI in general and wants to ask a question, now would be a great time to do that. don't see anyone unmuting.
I've got a quick question.
Sure.
Is there a recommendation for age on children to start checking their lipids on Trikafta?
So not yet. We probably need to come up with something. There are definitely people that are saying certainly by 18, it's probably good to get a baseline value to kind of see where you stand, particularly if you wind up having elevated cholesterol or something like that, so that you are able to intervene earlier before you start developing some of the more older adult associated diseases. So, but a lot of the data is still pretty early. I think the recognition that we're seeing these issues with cholesterol is fairly new. So we don't have specific guidelines around that yet, at least to my knowledge.
Hello, I do have a question. Can you hear me?
Yes.
Recently I'm like studying like a Trikafta has some issues with the mental health, and I know recently European also approved the Trikafta, and their label has the depression and anxiety as a side effects by taking this one. I know in the US we're not seeing that side effect enough when you buy that medication. Anything on the conference happened on this? Because first we didn't find it.
There was actually a strong focus on mental health in the conference, just in general, and also related to ETI Trikafta. I'll actually have a section on that, so I'll cover that in a little more detail a little bit further on in the talk. And if you have any questions about it at that point, we can talk about it then. But it's definitely a topic that is of significant interest to us as local providers, people who are taking care of individuals with CF, and for the foundation and the community as a whole. So, but yeah, I'll talk about that. There was a whole plenary on CF and mental health, and then a lot of sessions that I was going to that related to that.
Thank you very much.
All right, let me give a quick overview of genetic therapies. So obviously everyone's very excited about the potential of gene therapy. We recognize that ETI is very effective, but it's not really a cure. And of course, there's 10% or so of the CF population that's not eligible or can't take ETI for various reasons. So for that group, gene therapy may be their best hope for really effective therapy. So the plenary actually had a speaker talking about gene therapy in sickle cell disease, which may seem a little odd, but the idea was, one of the reasons we're so excited about the potential right now is that there have been a dozen or so, half dozen or more therapies, gene therapies approved for other indications, not CF, but other diseases, that many of which have proven to be actually really quite effective. Spinraza is one for spinal muscular atrophy, really game changer for that particular disease that's otherwise often fatal in infancy. So the idea is that, after years and years and years of saying, oh, gene therapy is right around the corner, actually for some diseases it's here. And so that raises hope that maybe for CF, it's going to be here as well. There are, in the plenary, they had a plenary on this. There are 6 therapies that are either at or near phase 1 trials that are based on different strategies. So there's different ways of trying to get effective expression of CFTR within the cells. So some are based on RNA, some are based on viruses, some are what they call gene addition. So the truth is there were about a half dozen therapies in NACFC 2022 that were also at phase 1. So we really haven't made huge amounts of progress over the past year. Things are definitely moving forward. So some of the phase 1 trials were very small, like 3 individuals, and they're moving forward into larger. And some are actually hopefully going to hit phase 2, which will be more. So phase 1's really, for those of you who aren't familiar, phase 1 trials are really about safety. They're not really about efficacy at all. Phase 2 are more about dosing, and with some efficacy measures. And then phase 3 are the big clinical trials that actually show if something works or not. So we're at phase 1, maybe getting into phase 2 for some of these therapies. It's probably going to be a while. it's a tough slog. Gene therapies in the lung are actually really challenging. You probably have to get your therapy very deep into the lung, into the smallest airways, because that's where most CFTR expression is, and that probably is the target cell. And there's a lot of barriers. There's mucus, there's inflammation, there's a bunch of things. Your lungs actually pretty well evolved to protect itself from the environment. And for better or worse, gene therapy vectors are sort of environment. So the lung doesn't like to let things in. And so we have to find creative strategies to overcome those barriers, which we're doing and we're working on. But there's probably going to be a lot of work that will need to be done before we're really at the point where we can have, at least for the lung, truly effective gene therapies. But there are a lot of bites at this particular apple, and the foundation is funding a number of different strategies that are based on very different approaches towards gene therapy, some viral, some lipoprotein, and even other strategies, and then very different ways of actually correcting the defect. Like, do you just put an RNA in? Do you use CRISPR to edit the gene to make it functional again? Do you change the splicing? So it's optimistic in the sense that they're not putting all their eggs in one basket. And if one approach doesn't work, there's a half dozen or more in the queue that will be tested. So, but we're still early days there. Any questions about gene therapy? Yeah, they actually, back in June, there was a CF research conference that's different from NACFC that was excuse me, focused on gene therapy. And it was really interesting to see all the different approaches, but it also was a bit of a reality check in the sense that a lot of these things are still at very early stages, being tested in certain types of models and not necessarily in airway epithelia yet. So a lot of potential, but still a lot of work that needs to be done. Okay. So if there's no questions about gene therapy specifically, I'll talk a little bit about microbiology. So they showed a lot of data about infection rates in CF. And what you see is, since 2019, the rates of things like Pseudomonas, staph, other bugs have actually dropped considerably. The challenge with that data is that the other thing that happened not long after Trikafta was introduced, as everybody knows, is the pandemic. And we all started isolating and we all started keeping away from each other. And it turns out, in terms of infection, that was a great way to avoid infection. We saw, for example, rates of CF exacerbations requiring hospitalization dropped quite a bit. But not only did they drop in the 12 and over group that was eligible for Trikafta, but they dropped in the younger ages as well that at that point were not eligible for Trikafta. So a lot of it was just, if we're not in school, if we're not having parties, we're not spreading the viruses around, we're less likely to be infected. So it's very hard to know, to tease out what of this is drug related and what of this was pandemic related. That said, as we've gotten into 2021, 2022, we haven't seen the rates of, say, Pseudomonas or staph jump up quite a bit as we've relaxed our pandemic era restrictions. So hopefully a lot of this is reflective of benefit from Trikafta. So, one challenge that we're having now is that a lot smaller percentage of people are producing sputum, which used to be our go-to and was a very good source for looking at infection. So we're much more reliant on the deep pharyngeal or oropharyngeal cultures that we've always done in the younger kids. And we know there's been study after study that shows the sensitivity of those cultures is not as good as a sputum. So if you see a pathogen, you feel comfortable it's probably there. If you don't see a pathogen, you don't know if it's not there or if you just didn't capture it. So there are people looking at different technologies like PCR based and whatnot to as more sensitive measures to try to look for some of these bugs to make sure that we're not missing something because we're not getting good sputa. Those are all still fairly early stage, but we may see some of that come into the clinic in the next few years. Then the other thing that was discussed related to microbiology was a lot of trials on exacerbation. So for those of you who don't know, our approach towards treating exacerbations, particularly in the inpatient side, is really based on history and not necessarily science. So, we've treated for, say, 2 weeks. And when I was a fellow, we often treated for 3 weeks. And there's no evidence that sort of supports this versus that. And so there's a series of trials that are all called STOP, the acronym, that are trying to really look at how should we be treating exacerbations when they occur. And I won't go into all the nitty-gritty details of each of these studies, but the overall suggestion is that shorter courses of antibiotics, at least IV antibiotics for an inpatient admission, tend to work about as well as longer courses. So in this study, they randomized people to either 10 or 14 days of treatment, or if you weren't really responding, either 14 or 21. And so 10 days of treatment had the same short and long-term outcomes as 14 days of treatment, and 14 days of treatment for those that hadn't responded as well had the same short and long-term outcomes as 21 days of treatment. So we are getting to the point where we're feeling more comfortable saying, oh, we can treat you for a week or a little over a week. And if you've responded and you're better, that may be enough. It also lets them sort of settle in on a standard treatment protocol for doing further testing. So one of the things they want to do is now look at how many antibiotics do you need? Do you really need 2 IV antibiotics for Pseudomonas? Can you get by with 1? Do we need to do these really aggressive regimens, or can we stick with simpler ones? So they can settle in. They've sort of settled in and said, well, 14 days of therapy seems like a good standard. And so that's what we'll do for these other trials where we're looking at how many antibiotics we need to use, for example. And there definitely is a recognition that CF on ETI is different from CF not on ETI. So CF, if you're not on ETI, that's more the classic historical CF that we've all been treating for years, but it's different if you're on Trikafta, which is not a surprise to anybody. But it probably means that when we come up with guidelines for how we're supposed to treat things, they may have to be different depending on whether or not you're on Trikafta or some other highly effective modulator therapy. Any questions about bugs or exacerbations?
Any came on like a Trikafta or anything on regarding the ABPA? I know, understand you mentioned Pseudomonas was not seen much in 2019-20. Anything on Trikafta with ABPA?
Yeah, that's an excellent question. It wasn't in this session, and I'm trying to remember if there were any posters or workshop presentations on that. My recollection is that IgE level, so IgE is an antibody that goes up when you have allergies, tend to go down with treatment with ETI, but that's a little different from so with ABPA. Your IgE levels are really, really, really high. And I don't know. I'd have to look and see if there were any posters that looked at this, but there weren't any sort of major sessions that I can recall saying that Trikafta clearly had an impact. Although at least my own anecdotal experience is that patients who had seasonal allergies that were complicating their CF, for whatever reason on Trikafta, their allergies seem to be a little bit better. I don't know if that's just a general reduction in inflammation. So my suspicion would be things like ABPA would get better, but I don't actually know that I saw any data on that.
Thank you.
I have a question too, Dr. Esther. Are there any antibiotics in the pipeline, like specifically like for NTM or anything?
Yeah, so there definitely are. I don't have a list of them, but there are new. So, the challenge with NTM is that relatively few drug companies are interested in developing antibiotics specifically for that indication. So Arikayce was probably the one exception to that rule. So that's the bad news. The good news about NTM is that drug companies are very interested in developing antibiotics for resistant staph. And it turns out that there's a lot of overlap between antibiotics that work for resistant staph and antibiotics that work for, or resistant other organisms, and antibiotics that work for NTM. So there are several drugs, both that have been approved recently and that are in the pipeline, that appear to have some efficacy for NTM. So we are making some improvements on that score. I think some of you may know, so for those of you at UNC, Dr. Ken Olivier is one of the world's experts on NTM, is at the NIH for many years, but was just recently recruited and started, I think, about a year ago here at UNC. So we're actually really interested in ramping up some of our research efforts. He's involved in both the clinical trial side, but also in the translational basic science side. So we're hoping to be able to do more looking specifically at that, and trying to figure out if we can come up with new treatment strategies, because it's still a difficult bug. Although we were talking about it the other day at our division meeting with Dr. Olivier, and both of our impressions is that we're seeing less of it with Trikafta, but not none. And we're definitely having patients that are still struggling. I didn't talk about phage therapy, although that, because I'm not sure that it was mentioned actually as part of that symposia session. I don't know if people are familiar with phage therapy. So the idea of this is that there are these viruses that are evolved specifically to attack bacteria, and usually actually very specific bacteria, even down to like the species or subspecies level. And they're completely harmless to people, right? They don't affect people at all. And so the idea is, these would be great drugs to use for resistant infections because they're tuned to kill the bacteria. That's what they're there for. And they're really harmless to humans. So there's been a lot of excitement around that. It turns out to be really challenging because you actually have to screen libraries of thousands or tens of thousands of phages for each particular strain of bacteria that you want to treat. So most of the programs that do this, you have to send an individual patient's bacteria out to their lab. They'll screen and try to find the one or few phages that actually kill this particular bacteria. Sometimes they have to genetically modify it to make it more lethal to the bacteria. And then that's what you use for therapy. So it's hard to scale, but definitely something that's available for patients who are really running out of other options. And at least the data that I saw that was presented in the plenary, they had said about 70% of patients that they've treated seem to have at least a positive response of some sort. One challenge is that even though it's not harmful to people, you do develop an immune response to the phage. And so the body can actually work against you in the sense that you actually develop antibodies against the phage. And so on the second or third round of therapy, it's not as effective because the patient is now clearing the virus. So there's still, so a lot of excitement around it, a lot of ideas about how phage therapy could be used in various ways, but still kind of early phase, but early phase with a few real true clinical successes, but not something that we can scale up and say, oh yeah, everybody who has these infections will respond. So. All right, any other questions around microbiology or exacerbations? All right, so the last really major topic that was covered at the meeting was mental health. And I think a lot of people are really interested in this. So there was a whole plenary on this. I think the basic concept that CF can cause issues with mental health has gained a lot of traction, certainly in the past 5 years. We've been doing, I know in Chapel Hill, and I think other centers are routinely doing mental health screening, mainly for anxiety and depression. And they showed some data that screening rates are improving, really just probably over the past 5 years. I think to the point where 70 to 80% of individuals followed in CF centers are now getting routine mental health screening. So that's that's really great. We've uncovered a lot of things that we didn't realize when we weren't screening. So, but those were important things to note. And there were some things, so we talk about mental health, and I think our natural focus is on the people with CF and their families, and I think rightly so. But there are also a lot of issues with mental health and providers, so concerns about burnout. And so part of the plenary was actually talking about that and trying to find out strategies. COVID-19 took a pretty big toll on providers, and we're getting out of that now, but still risks of burnout, still risks of just feeling like you're running uphill constantly. And so there's a lot more attention to that on the provider side as well. But one thing that certainly interested me quite a bit was the relationship between mental health and Trikafta. So anecdotally, we're seeing this a fair amount. Patients feeling like they're more depressed or more anxious while on Trikafta. And there was a lot of different sessions on this at the conference. But it was interesting to see. So several groups have looked at, because we've been doing these anxiety and depression scores routinely, they've been looking at, well, do they change after the introduction of Trikafta? Now, of course, at least for the 12 and up crowd, we have a big potential confounder, which is we started Trikafta, and 6 months later, we were in a pandemic. And the pandemic clearly affected people's mental health. So it's really hard to tease out whether effects on mental health were related to Trikafta, the pandemic, or some combination. But as a general rule, the bigger studies, so if you look at the population as a whole, don't see a lot of changes in these scores. So GAD-9, PHQ-7, those anxiety and depression scores don't change in the population as a whole. And that's been published a few times, and there were a number of other posters looking at it within different center populations that showed more or less the same thing. On the other hand, anecdotal experiences of people seeming to have mental health issues after starting Trikafta are actually pretty robust. There was a report that looked at adverse events reported with Trikafta, and while mental health was not one of the more common ones, anxiety and sleep disturbances were the most common mental health issues reported with Trikafta. And certainly our anecdotal experience suggests that there are some patients that seem to have trouble with that. So there were a lot of reports looking at that, and several suggestions that there are interventions that can help. There are actually a lot of sessions on different types of strategies, like behavioral therapy, medications, showing that they do indeed provide benefit for anxiety or depression within the population with CF. We've done a lot, and there were studies presented on things like dose reduction. So if you say use half the normal dose, can you reduce anxiety or depression in patients that are experiencing that while still maintaining a lot of the clinical benefits? So, and overall right now, the evidence suggests that yes, you can. But again, we're definitely still in the anecdotal area where we're reporting on a small subset of patients from a particular center and not necessarily like a big clinical trial type of study. But it definitely was presented quite a bit at the conference. So questions on that, on mental health?
Any specific age with the Trikafta with the mental health? Is it like in the kids or is it like in adults? Is it anything published there?
On the on what might cause it?
Yeah, Trikafta means Trikafta who has
Yeah,
taking the Trikafta? Is it like a 12 and above, or is it like some age anything research was done, or is it like general only?
Yeah, I don't think we know much about mechanism yet. It's something that's been of interest to me in particular, and I think our group, and we just haven't had the time to do the types of studies. But the components of Trikafta are very, very hydrophobic, meaning they cross, which means they cross membranes relatively well. There have definitely been a few early studies that show that there is measurable Trikafta in the brain. And what we'd really love to do would be to try to look at that in more detail and say, like, how much of it gets into the brain? Do all three components get in? Where does it go? Is it involved in centers that we think might be related to anxiety or depression? I've had conversations with people about like looking at animal models. There's a lot of interesting tests you can do to look for anxiety in a rat or a mouse. There's one that they call the Fruit Loop test, which I thought was amusing. But yeah, you teach them that Fruit Loops are good, and then you put a Fruit Loop like across an open space, and rodents generally don't like to go into open spaces unless they feel comfortable. So the longer it takes them to actually get that Fruit Loop, the more anxious they are. That's the Fruit Loop test. So I'd love to see something like that done with animals on Trikafta, but I haven't seen it yet. So
Thank you.
all right. So I feel like I've sort of run through my 4 major topic areas that were covered at the conference. Obviously, there's a ton that I did not talk about, and of course, a ton that I didn't even get to see because there's multiple sessions running in parallel. And I didn't think you'd want to hear about mass spec biomarkers in any great detail, so I saved you from that. But I'm happy to answer any other questions as best I can about what happened, either what's happening in general or what happened specifically at the conference.
He knows that too. Yeah.
Hi, Dr. Chuck. It's Krista, your biggest fan. I do
Hey,
have a
Krista.
Greg updated me on that question. One question I had that was already answered, but the other one I have is: are they discussed pancreatic insufficiency like meds, and for those patients that are not improving on Trikafta?
Well, let me start with one thing that actually, it was a great point, and I meant to mention that because it's something that actually our group just published on recently in the journal of Cystic Fibrosis. So we've actually known for a while that a subset of patients on modulator therapy will regain some pancreatic function. So that actually even occurs with old drugs like Orkambi and Symdeko. But we're definitely seeing that with Trikafta as well. We've now been screening for fecal elastase in everyone with that's on Trikafta, or at least trying to. I think one of my largest professional failures so far has been convincing adolescent females to give us a stool sample. That does not typically go well. And so we're definitely seeing it. If you have some residual pancreatic function to start with, you're probably more likely to respond to the modulators. And we think, but can't really say with certainty, that the earlier you get started on modulators, the more likely you are to regain pancreatic function. I do have an infant that was sort of trending down in terms of her, and actually we started her on enzymes, but then she was eligible for ivacaftor at 6 months, and within 6 months of being on therapy, her pancreatic levels were coming back up, and we were able to take her off enzymes. But that said, I actually have a college student that I recently took off enzymes. So it's not necessarily like you for sure have missed the boat if you weren't lucky enough to be starting on Trikafta at age 2. So I think that partially answers your question, but I'm not sure it fully answers your question.
Partially, because I'm making this relevant to myself, and I apologize to everyone, my child who cannot gain weight. And so I just wonder if there's anything new. I periodically have seen some studies come through. I just didn't know if there was any progress.
Yeah, I don't think anything that that has gotten to the level where we could actually develop some sort of therapeutic application out of it. There's definitely changes in the gut microbiome that occur with ETI, and of course with any of our treatments, antibiotics and whatnot. What I'll say is that the CF gut pathophysiology has been woefully understudied for many years. Everyone was pretty much focused on the airway, and I guess reasonably so, since that was typically the biggest cause of morbidity, mortality. But what actually is happening in the gut, how it's responding to ETI remains a little bit of a black box, but one that the foundation is particularly interested in. We actually have two investigators at UNC that just got grants through a GI focused mechanism to be looking at different cell types and different things. So I think we're in good shape to start making progress on this to better understand, what goes on in CF, what happens when you're on ETI, and your particular issue is actually not that uncommon. So what I've seen, and this is more my own experience and necessarily something that was reported at conference, but on average BMI goes up on patients on ETI, and of course we have some people that we start getting into the obesity range, which I mentioned before, but that response is pretty variable in my experience. And and although I'm not treating your son anymore, he wouldn't be, if I were, he wouldn't be the only one where I'm still struggling with weight and nutritional issues. So that's been interesting. So exacerbations drop almost to a person. Lung function doesn't always go up, but even if it doesn't go up, it stays stable for the most part. So the airway responses to Trikafta have been pretty consistent, but the gut stuff is really much more variable. But unfortunately, yeah, we don't. It's an area of focus. It's definitely something that we recognize we need to know more about. And of course, we're very gratified to see that a lot of patients are regaining pancreatic, well, maybe not a lot, a subset of patients are regaining pancreatic function. And of course, we're hopeful that maybe with prolonged therapy, we might see even more gains. We weren't optimistic about this at first. So here's my, does anyone know what organ cystic fibrosis was named after? It's my little trivia question. Yeah, back in the 50s when CF was first recognized as an entity, it was actually, the full name of it is cystic fibrosis of the pancreas.
That was my.
So it's actually named after the pathology they saw in the pancreas, to distinguish it from other pancreatic causes of nutritional insufficiency. So, and the reason that's relevant is because when we used to do abdominal CT scans of patients that were adolescent or young adults, we'd often just see what looked like scar tissue where the pancreas used to be. And that's why patients with CF were prone to diabetes, right? You were basically destroying the whole pancreas, and the diabetes producing cells were just innocent bystanders. So, but, the body surprises us. And maybe when you get rid of some of that, when you actually activate CFTR, maybe you can regain some pancreatic function, even though we thought your pancreas was pretty much toast. So we're much more optimistic now, but there's still a lot that we need to learn. And then in terms of, why do some people not seem to respond from a nutritional standpoint to ETI the way that others do, we're still a little bit in the dark, but definitely starting to shine some light.
I just had another on the same note. Is it anything the therapy can be cut or reduced when the people started the Trikafta? Anything came? The research, like then they can take out the hypersol, they can take out the albuterol.
Oh, right. Yeah. So some of this was addressed at last year's CF conference. That's when they reported the Simplify study. So Simplify was a study where they took people that were on hypertonic saline or pulmozyme or both, and told some of them to stop and the others to continue, and measured lung function at 6 weeks. And they said in that particular study, and they picked 6 weeks because when you start these therapies, you usually see the benefit within 6 weeks. So they figured 6 weeks was the amount of time on therapy or off therapy where we would see something change. And they said, if lung function changed by 3%, predicted FEV1, we would consider that meaningful. And it turns out it didn't change at all. So it didn't matter whether you stayed on hypertonic or stopped it, your lung function was the same. Didn't matter whether you stayed on pulmozyme or stopped it, lung function was the same. In fact, there was a sub-study that actually looked at mucociliary clearance, so how quickly you get things out. And it turns out, so if you were on ETI, so I should preface this, these were all patients that were on Trikafta, and you stayed on pulmozyme, your mucociliary clearance was actually a little bit worse. And that's not crazy. We've seen that in other non-CF diseases where people have tried pulmazide and it doesn't help, or sometimes it occasionally makes things worse. So it may be that you need a little bit of DNA hanging around to help get things out, but too much is a problem. And if you're on Trikafta and your inflammation drops, then you may not benefit from pulmazide anymore. So there haven't been studies that I've seen about airway clearance. I will say most of my families that are on Trikafta have pretty much stopped doing their regular therapies, whether inhaled or chest PT. And at least on an, again, more anecdotal basis, they seem to be pretty stable with their lung function. So that's not evidence, that's stories. But and then enzymes, and again, I'm probably speaking more from just general experience than from what I heard at the conference, but we're seeing a lot of patients that feel like they're getting constipated on their previous enzyme dose, and have either with or without our permission reduced the amount of enzymes that they're taking. And then again, there are a few where we've tested them and been able to show that they don't need the enzymes anymore. So yeah, I think a lot of reduction in therapies. There are several studies ongoing, sort of real world studies that are trying to look at this. I think the challenge they're going to have is that, the word's getting around, and it's getting harder and harder to convince people that they should stay on these therapies when they don't feel like they're seeing much benefit. And they hear from a whole mess of people that have stopped them that that seem to be doing well. Now, I should give a big caveat, right? I'm a pediatric pulmonologist. I'm not an adult pulmonologist. And so most of the patients that I see have not developed enormous amounts of lung disease. If your FEV1 is 50%, I'm not so sure that you can get by without your inhaled therapies, your airway clearance. So I'm certainly not advocating for that for everyone. And we are advocating for resuming some of those therapies with an illness. So if you get sick, you get a virus, go ahead and restart your hypertonic, do your airway clearance. But yeah, so the Simplify study came out last year, like right before the conference last year, and there are real world studies going on, but I don't recall hearing any results from them at this past NACFC.
Thank you.
Do you know if Trikafta is reducing the occurrence of CFRD?
So we don't know. So the evidence we do know is that patients on Trikafta tend to have improvement in diabetes related parameters like hemoglobin A1C, glucose levels, etc. We're probably too early in treatment course to know whether it's really going to reduce overall rates of CFRD. Certainly one would be optimistic if we're regaining pancreatic enzyme function. That would mean that those enzymes are now getting out into the gut where they're supposed to be and not sticking around and digesting the pancreas, which is what happens in CF. And if that's true, then one would hope that would reduce the incidence of CFRD. But I don't think we're far enough into the course. CFRD takes a long time to develop. It's a later stage thing. And so while I'm optimistic we'll eventually see lower rates, I don't think we have the evidence yet. But it is, again, we haven't proven it, but our suspicion is that starting early may help preserve pancreatic function. And it does kind of change the calculus a little bit on how soon you should really be starting it. There's a bunch of 2-3-year-olds with CF running around and they seem fine, right? They don't seem to have a ton of lung disease. They're not getting sick quite a bit. And it's probably more of a theoretical question. I don't know a lot of families that have chosen not to pursue Trikafta at that age, but it's at least been raised. But even if you're not worried about lung disease, or you say, oh, let's just wait, if lung disease develops, we'll start Trikafta then. This issue of the fact that modulator therapy may allow pancreatic function to resume, might push people into doing it more at earlier ages. Even Orkambi, which is now approved today down to age 1, and is really not a terribly effective drug in terms of respiratory symptoms, although it does reduce exacerbations, has been shown to improve pancreatic function, at least on the population as a whole. So, I haven't typically sort of pushed Orkambi really early because I've been focused on lung disease, but I've been rethinking that about, if I can start them on Orkambi at 1 and then switch them to Trikafta at 2, is that the best way to give them a good shot of getting their pancreatic function back? Okay, so other questions, either about conference or just CF in general?
Thank you very much for speaking and sharing, your expertise and time with everyone.
Oh, happy to do it.
Are there any other questions from anyone?
No, I just want to make a comment on how much we appreciate Dr. Esther making this presentation, all the questions and comments, and just our appreciation for all of our care centers and the leaders in our area serving people with cystic fibrosis and their families. Thank you all for everything you do every day.
Well, you're welcome. And I'll make one last plug. So for those of you who weren't able to attend the conference but would like to hear more, all the plenaries and several of the sessions are online, and I think more will be coming up. So just go to the NACF conference site and you can watch the videos and learn more.